Well, thank you so much again for the kind invitation. I feel like very privileged to be here. This is my second time. This time I brought my daughter. I think third time I'm going to bring my family, whole family here. Uh, that is one. Number two, I think the meeting is amazing. I told Helen that you are organizing a better conference than Houston, so maybe we should have her on board for the next conference in Houston. So I wanted to talk, I started working on MECP2 duplication syndrome in 2018. Dr. Zogby asked me to take the clinical and translational part of the MECP2 duplication. Now we are we are very lucky for a rare disease, for ultra rare disease MECP2 duplication is considered. We have at least two trials are kind of ongoing, and there are potential for other trials that you are going to hear later on today. So we are very privileged for the MECP2 duplication community that we have it. In my background, other research, I do gene discovery for other rare neurogenetic syndromes, and there are 8,000 different syndromes. And I know that they are all begging for treatment options for this, but we are lucky in the MECP2 duplication world. I wanted to reiterate that first. So I wanted to, since 2018, I wanted to say where we are at today. So my first talk is about what did we achieve and where are we and where we should go. So that's the main purpose of it. So I'll start with what did we achieve so far. I'll start with this slide from 2020 Houston conference. Okay, as you can see, at that time there was the mouse model and Dr. Zogby's lab did the pharmacodynamics or pharmacokinetics of MECP2 duplication in mouse models. That means you give how much you should give, how much is the dose is beneficial, and how much is toxic. And so these were all achieved. But there were two things that they were pending. That was the developing biomarkers. Biomarker means I explain it to the families like this. For example, you go to doctor, you are found to have cholesterol, right? So doctor checks your blood cholesterol level, and based on that, you get dose of the medication, the cholesterol lowering drugs, right? So there's nothing for brain disorders. We said whether can we achieve something to develop biomarkers for brain disorder, especially MECP2 duplication syndrome. And the other part was for the clinical trial, we needed severity scales and outcome measures. What does this mean? This means, for example, when you go to regulatory agencies like FDA or the European Medical Agency, I don't know what was it called UK, but they are going to ask, how did you measure the severity, right? So you wanted to have outcome measures for MECP2 duplication syndrome, and also genetic studies, you always hear from me talking about it. So I'll start with the biomarker part. So first of all, I would like to thank Ionis that launched this trial, supported us. And we launched this, we call it clinical, Ionis calls it clinical trial readiness study, we call it biomarker study. So we had aimed 3 biomarkers. Okay, one is the molecular biomarker. The molecular biomarker is the same as the cholesterol, as I told you. So that shows the early detection. For example, if you don't follow your cholesterol, your outcome is you're going to get a heart attack or you're going to get a stroke to the brain, right? So that is a clinical outcome. But the cholesterol is an early stage that you can predict the disease. The neurophysiological biomarker, this is, if I explain it here, when there is a change in your DNA or RNA, it rapidly translates to protein. That is, protein means they are the acting elements of the cell. Then it makes changes on the neurophysiology. Neurophysiology is electrical activity. For the brain, you can talk brain's network activity. For example, you have a hearing system that and you hear something, it goes to the brain certain part. That's called auditory evoked potential. Or for the vision, it's very complex, so visual evoked potential. Or you may know, for MECP2 duplication, probably several of you did EEGs. So there are abnormalities on the EEG, but you don't treat the EEG. You treat when there's a seizure happens. So neurophysiology is, again, early stages of the kind of disease where you are heading. And the last thing to change is the clinical features, as I said. Seizure is the last thing, or the developmental outcome is last. So these are the more outcome measures, and this was for safety biomarker. So we published this. This is a review what we achieved and what we didn't achieve. This was published just last year, okay? This is only the clinical and the neurophys part, okay? Here is the age distribution. Blue are MECP2 duplication, and red ones, or the red triangles, are the red-like patients, male Reds, we call it. We wanted to compare gender, same gender. I don't know if you know, Rett syndrome is mainly in girls, but there are very few males with the Rett syndrome as well. And it's much more severe than even MECP2 duplication syndrome, I can say it. So a nice age distribution. We did very detailed evaluation, developmental assessment, gait, actigraphy, like infrared, because Rett patients have very cold extremities, sleep study, visual evoke. There were more, but we did. So as you can see, some patients, we had 11 MECP2 duplication patients in there and 6 Rett patients. Some had 3 visits, some had 1 visit, some had 2 visits. It's because we were doing it in COVID time, and thank you for families who traveled during those like restricted times. Hospital was shutting down. They were saying that you can't admit a patient for sleep study because your hospital is full of COVID patients, right? So it was tough times, but thankfully we were able to achieve the early kind of biomarker studies from the MECP2 duplication and Rett. So what did we find? So this can be a outcome measure as well. So I wanted to mention 2 things. One is the stereotypy. I don't know if someone came to my clinic, I'm sure they know. Duplication kids have this like more hand flapping at side or here, or body rocking stereotypy or repetitive movements. On the other side, Rett patients have more midline stereotypy. Okay, so they hand ring, and it's much different than duplication. It interrupts with their hand function. So I don't know if you know, for Rett patients, when they have stereotypy, they have 0 hand function. They don't reach, grab, or do anything. Okay, so that's different. The other thing is tremor. I wanted to mention that first. I don't know how it's going to happen, but tremor, Rett patients, male Retts, not the female Retts, but Rett patients, they had whole body tremor. They are literally jerky to the level that they don't even gain weight because their muscle is jerking all the time. That's a constant thing. They require brain stimulation, like you're putting a metal into the brain to stop those movements, doing 2 or 3 different medications. But none of our duplications that I know of, they have tremor. So there were differences for sure. This can be, or the hand movements can be a safety assessment as well. For example, when we give too much drug, we are doing RNA-based treatment, ASO, right, now. So if you did suppress the MECP2 too much, then if you see kind of this type of movements to like more midline, then you're over-treating. Or if they are tremoring, then you're over-treating. So it can be a safety biomarker as well. But we know that Rett patients are not prone to respiratory infections. I know MECP2 duplications are cause significant respiratory infections, or the epilepsy is much more difficult to control in MECP2 duplication patients. So I just wanted to bring this one here. So 6 out of 8 patients who underwent sleep study I'm talking about the MECP2 duplication patients, they were not aware of the sleep apnea, and the other 2 were aware, but almost all MECP2 duplication patients, or very high frequency, they have sleep apnea. So I just want you to have, I think anyone with MECP2 duplication syndrome, they should have checked their sleep apnea is there or not. If it's mild, mostly you don't do anything, but sometimes if they're too tired during the day, or like it prevents them to participate in things. So I think they should have a sleep study, and if they tolerate the CPAP or treatment, that may help them. Neurophysiology, I'm not going to go to details, but we get the different parts of the brain. For example, this is temporal, this is the frontal, occipital. We found differences. These stars are showing differences between typical developing, like normal healthy individual, MECP2 duplication, and male Retts. So Dr. Marsh, Eric Marsh from Children's Hospital Philadelphia, is doing the neurophys studies for the natural history study and CS1. And also he did it for the US natural history study for the red centers, which is different than our Ionis natural history study. So it kind of duplicates or confirms the results of those studies. So, but this is still evolving process. It's going to continue. Molecular biomarker studies. I wanted to say that this was part of this clinical trial readiness or biomarker study. I had two wonderful physician scientists, Dr. Capuccio from Italy, but she is at Texas Children now, and Dr. Maletic Savetic. She is Serbian, she's MD PhD, child neurologist and geneticist. They led this initiative. This is important. I think there was one of the questions about the mitochondria and MECP2 duplication, but I will talk about it. So on top of the Ionis 11 MECP2 duplication patients and red patients, we collected another 30 patients that is funded by NIH, okay? So it was very comprehensive. It's beyond like what we tried to do initially, but we got the patients. It's not very visible. There is a man here, boy. I see here, yeah, sorry. Yeah. There's the boy. We got the cerebrospinal fluid and the blood. And we got also another blood sample and we converted to brain organoids, or they call it mini brain. It's literally from the blood, you can make small brain tissues. And now, the current FDA landscape, they try to avoid from animal studies to more organoid type studies. So you make a small brain in a petri dish, and you try to study the function of it in those mini brains. So we created that. On a side part, we did the mouse studies. We got their blood and we got their brain tissue as well. Okay, they underwent very comprehensive metabolomics and the proteomics from CSF, and also the CSF means cerebrospinal fluid, and the plasma is your blood tissue. So basically, you are checking millions of metabolites in the plasma and in the brain. And as you can see here, but there's a TCA cycle, or I can say that these are all energy processes that is mostly run in the mitochondria. Mitochondria is our energy producing part of it. And eventually we saw separation. This is too much for you in general. It's not gonna kind of, I don't expect you to understand all these details, but long story short, okay, let me go there. Okay. What we found, their mitochondria is severely affected. There were some early studies, they didn't like show it, or they showed some link, but this is the first time. Basically, we don't know how MECP2 duplication syndrome caused damage to the cell or our brain tissues. So now we know that it's through our mitochondria, and what happens that abnormal mitochondria cause abnormal DNA damage, or we call it DNA damage. This is the difference. You can see both DNA damage markers increase significantly in the MECP2 duplication, and the response to treat, like for example, when there's a DNA damage, our body tries to fix those damages, okay? That is there's a regulator or the kind of saving mechanism. So they are both increased. This study is about to be published in the next 1 to 2 weeks or submitted, but it's a groundbreaking paper that is showing how the MECP2 duplication syndrome causes disease in the body, okay? It took 2020 to 2025. We are submitting, maybe a year or two will take to accept that. So 6 years to run this study, just to let you know on that. Again, as I said, when there are two MECP2 duplication syndrome, this is the mitochondria. You see MECP2 duplication mitochondria. It damages that mitochondrial cycle. It causes, we call it reactive oxygen species, kind of abnormal toxic products. And they go and they damage the DNA. It causes chopping of the DNA. We found those things. And eventually it causes brain cells not to grow well. Okay, so we talked about the biomarker study. And the second part is, I'm going to talk about the genetics in the afternoon briefly, not too long, but outcome measure part that was assigned to me. I think we did a good job in there. So we did a meaningfulness survey, how meaningful the symptoms and everything, and we found the top domains, but we published 2 different papers. One was about the caregiver burden. It's a mini survey, 6 questions, just to let you know, Christine and Paul, like, Patients like shorter surveys, definitely. They are tired of filling surveys, but definitely it's a mini parental burden survey. Hopefully we are going to see with the treatment, they are going to see decrease in their burden, okay? And gastrointestinal problems are a very big issue for them, we know it. And we developed a gastrointestinal health scale that is kind of querying or showing the improvement. It's a parent field survey, both of them are. Communication is a big problem for MECP2 duplication. They can't speak, right? Or they mostly cannot convey what they want. And Dr. Bryce Reeve, he is at Duke. He is the expert for communication tool development. It's famously called ORCA, Observer Reported Communication Ability. So he developed it for Angelman syndrome and some other Rett syndrome, but like he's collaborating with Ionis and RSRT, and there's another one, together to develop this ORCA. It's kind of developed, we are using it in the currently run natural history study and clinical trial, CS1 or IOM for this study. And you know Dr. Peters, so she is leading the efforts with us on the CGI, Clinical Global Impression. This CGI is a very common tool that is almost used in every clinical trial for neurogenetic syndromes. It's our global impression about the disease, overall perspective. So it's being used as well, but we haven't published those yet. So yeah, we are going good, right? Are there something that we did not achieve, right? So that's the point. If you remember, well, let me start with this. Epilepsy is, we had done two meaningfulness survey, as I mentioned. One was published a couple of years ago, like both of them actually. This is from our parental meaningfulness and burden study, and this is from Dr. Newell, Jeff Newell. He is the MECP2 expert at Nashville. So this is the US natural history study. As you can see, seizure was our top concern for families. I know it because when the seizure kicks in and especially quickly becomes refractory, and it's a big, it takes a lot from our kids, okay? For the seizures also, it was number 2 or 3, actually it's number 3 in the US natural history study. This is the MECP2 duplication column. So here is the seizures. So it was very important. And Dr. Zogby asked me in 2022, do an epilepsy survey because, I mean, what medication combination works? Now we are in the AI era, right? We can use the mechanism, maybe published literature, and with the survey from families, combine all 3 of them and come up with this medication combination works, okay? And the other thing is, this is the landmark study from Dr. Zogby's group about the ASO in the 2015 Nature paper. This is the healthy mouse. This is their EEG. You see there's no seizure. And this is duplication mouse, okay? And you see a lot of seizures in the MECP2 duplication mouse. But when you treat them with the ASO, almost like seizures are completely gone. So I am very hopeful that, and even when the older aged MECP2 duplication mouse are treated with ASO, their seizures improve significantly. So we are very hopeful. But just to let you know, as a translational researcher, I can say, you see perfect response in mouse, doesn't mean that you're going to see the same impact on the human. So that's why we needed that survey. So we launched it last year around this time, okay? So 51 surveys were completed, okay? But there is always like incomplete or some errors and everything. So in the end, we were left with 27 valid responses, okay? I know it was a painful survey, but to understand comprehensively, we wanted to get the most information from it, we needed to design that way. Long story short, as you can see, a lot of these are the medications. A lot of patients had only one medication. Only one, not one medication they are on, but at least like the information was limited to one medication. Only one patient, 3, or 3 patients, 3, and 2 patients, 2. So long story short, overall, the results were too small to make big conclusions, but I can say that it said that Keppra or levetiracetam showed the best treatment effect. I doubt about it because in all around the world, almost all neurologists goes with the levetiracetam as the first-line seizure medication. And this is the mildest or has the lowest potency for treating seizures. It shows that benefit. That's true because when they are started on it first, they show some benefit for sure. But that's why I don't get that result properly accurate. And doesn't have too much side effect. We all know that Keppra doesn't cause side effect other than some like little bit aggressiveness of behavioral issues. So it is very safe medication. So no surprise there. I don't know if you know, like I always say, there are a handful of families definitely with clobazam have strong side effects, right? The main problem is clobazam is a benzodiazepine. It's a sedative drug. If you give too much, it's going to stop your breathing. It's going to stop your heart. So that's why it's risky for benzo, especially the breathing. That is, and decreases muscle tone. So it's understandable, MECP2 duplication is a low muscle disease, and if you give another muscle relaxant or like body relaxant, brain relaxing medication, it is cause regression in them. So I take this part, zonisamide doesn't cause too much side effect other than kidney stone, and if you are hydrated and no family history of kidney stone, we don't expect that. So long story short, this is a thing that we were unsuccessful. Patient number was too limited, like too little to make a good conclusion from the study. I don't know if we can do or not. So I wanted to briefly mention, or like not briefly, but like go a few other ideas. What studies can we do? I wanted to pick your brain. I want you to actively respond, like what do you think about these studies? The one of them is just curiosity also. It's like, how frequent is MECP2 duplication syndrome? This slide was from my 2020 presentation, okay? There are two different studies, okay? This is from 2008. MECP2 duplication was discovered by Dr. Van Esch in 2007. So 1 year after that. So it was the era everyone was checking whether their patients had MECP2 duplication or not. This is this green one, the big tall thing is MECP2 duplication. And as you can see, this is Baylor Genetics. It's a commercial lab at Baylor. It was the most common copy number variation in our DNA, this huge green line. And it, like, for example, this is 1p36 deletion, 1p36 deletion. We now know the frequency is 1 in 5,000. Okay, it was big more than that, and it was more than 22q122 deletion. This is a DiGeorge syndrome. You may not know it, but so frequency of it is 1 in 3,000. So these are super common, or relatively very common neurogenetic syndromes. And at that time, MECP2 duplication was very common. So how come it's now common? Because now another study is claiming this is still possible as well, because this is a registry based on Australian registry, Australian pediatric surveillance. So that's why I took it more legit, because this is just a lab result. So what they found, 1 in 150,000 individuals. So which one is correct? If you look at it, maybe you're expecting something 1 in 5,000. And if you look at it, this is 1 in 150,000 live births. Males are 1 in 100,000. So which is correct? Is it really important to you? This is kind of important. Why? Because if you have a more common disease, that's going to attract pharma companies more to invest there, right? Or from regulatory standpoint, Rett syndrome is about maybe 10 times more common than MECP2 duplication. They have a very strong voice, right? So they can go to their local representatives, they can advocate for the disease, and they can get more benefits, privileges from the insurances and everything. So that's why frequency is important. Paul, you're going to hear from him. He gave the nice idea. It was 2 weeks ago, like a month ago or so. So we have NOMAD. This is at Harvard, there's a sequencing database. They are sequencing a healthy population. NOMAD has around like 700,000 individuals. They are presumed healthy individuals. Okay, about 500,000 of them have the copy number variation that you can detect deletions, duplication. So we have that healthy population, 500,000 healthy individuals from US. And I don't know if you heard UK Biobank study. This is an amazing study that's run by UK. I think government and big pharma companies are supporting that. So far, they have 500,000 individuals They have more, but I think the genomic part for this copy number variation, deletion, duplication calls, they are bringing these individuals every so often. They are doing MRI, metabolomics. They are doing huge studies or heart studies, whether they have any heart condition. They are going to follow them for a long time. This is a huge resource for the entire kind of health system, or also entire kind of scientific community. So we are all very excited about it. So they both have around 500,000 individuals. And I'm going to show later, but in MECP2 duplication syndrome, about 80% of the MECP2 duplication is inherited from an unaffected mother. So that is going to kind of reflect, a big majority of them are carriers, right? Will reflect what is the carrier female frequency in the population. This is an ongoing study, but I texted one of my bioinformatics friends. It looks like it's pretty common, the female MECP2 duplication carrier. Like the numbers shows to be 3%. 3%, when you look at it, I think it's going to be probably 1 in 5 to 10,000, roughly estimate. But we will see. But this is, and I think a study needs to be done. And we are going to work on it, hopefully. So, symptomatic females. I don't know if we have any female MECP2 duplication patients here, but I get call from, I see from families are reaching me out. They're saying that, oh, my daughter has MECP2 duplication syndrome. We did a lot for the community, which is true, and I'm very thankful for them. Why my child cannot be in the trial? Because we are currently doing it only in males, right? So to do that, we need to kind of see where the situation is with that, okay? So to overcome, what do I mean with that? For example, how many female MECP2 duplications are there? Or are they really fitting to MECP2 duplication, or can they have something different? Because several, like as I said, 80% carrier mothers don't have any problem, right? At least apparent problems. So why those females have it? So that's the reason a group of red centers, there are like 15 to 20 red centers. I think a handful of them participate in this. Thanks to Ionis again. They kind of helped us with this project. So we went over the entire literature, okay? How many published female cases are there, okay? And this number is after excluding, like not confirmed or not really fitting to the diagnosis thing. So solid for the 3 females, okay? Also, we have now 7 patients from MECP2 duplication cohort that we are planning to publish, but we wanted to publish this part first. And here is the data from them, okay? And this is, to me, very exciting. Why I am saying it? Because it matches with what we published last year that I'll show, our big genotype-phenotype paper. So we split into kind of 2 to 3 groups. One is a regular MECP2 duplication, and the other one is translocation, terminal duplication, and maybe triplication group. As if you know, or I talked 2 years ago in every of my talk, and I'm going to talk in this afternoon, this is milder, this is more severe. And did we see it? When we compare their intellectual disability, the severity of the syndrome, I will go show in the next slide, but this is 7 out of 24, which is about 20-30% are severe, but here it is like 66-70% are more severe. So it's more severe in the terminal duplication. Same, many features, they are like congenital anxiety is reported in all mothers, okay? Or the compulsion. It's weird because in this is the same table. Here, there are different scales. This is SCL, NIDR. This is the psychiatric history. This is important. If you see anxiety, 8 out of 8, right? But when you do a test, standardized anxiety test or psychological assessment, 5 out of 8 has anxiety. So, for example, if you ask me, am I depressed? I'm going to say depressed. But depression is a diagnostic scale. 5 out of 9 features has to fulfilled in the last 2 months. So you may feel you're anxious, but in the reality, that's a normal human nature response. A little bit anxiety doesn't mean that you have an anxiety disorder. Why this is important? I don't know if you heard Fragile X syndrome. Fragile X is the most common intellectual disability disorder, just in males. Most common male intellectual disability disorders. Frequency is 1 in 3,000 or 4,000. And there are at least 2-3 companies are doing gene therapy trials for this now. Oh, not the Fragile X, sorry, Angelman is the one that does. But Fragile X has a lot of because it's very common. As I said, a lot of industry is interested in that. For Fragile X carriers, they have premature ovarian failure. Premature ovarian failure means like you are going through menopause early. That's why you are going into early menopause. Or it comes with other symptoms, whatever. Or there is Fragile X ataxia syndrome. Fragile X carriers in their 60s to 70s, they have this ataxia, tremor, ataxia. That's called FX-TAS or Fragile X tremor ataxia syndrome. Because of that, National Fragile X Foundation, they notify you. Do you struggle to get pregnant? Or so it's kind of a thing related to the Fragile X syndrome. Now they're screening for this kind of problem. So should we do it for MECP2 duplication syndrome? So what I'm going to say here, again, 80% of MECP2 duplication is carrier unaffected, obviously unaffected carrier mothers. And the problem is, as I said, that survey shows actual diagnosis of anxiety is 5 out of 8, but they feel that they are anxious in all of them. So carrying a child with MECP2 duplication is causing huge anxiety to you, right? So I wanted to briefly mention our burden study. This is the one burden scale came out of it. 84% of the MECP2 duplication parents reported that they struggle to find a local expert who even heard the MECP2 duplication once in their life. They even didn't hear it before. So that caused huge burden to the family, right? But 85% of the families reported that they are anxious about the progression of the disease. Taking care of an MDS, again, 85% reported that taking care of an MDS individual affects their life, social life, moderately to severe, 85%. It's huge. Moderate to severely affects their anxiety and social life and its relations with their spouses. So it has huge impact on the families, right? Or about 65 or 75%, it affects their job or the personal aspirations. Financial well-being, U.S. health system sucks, like financially, like it drains your money, even you have insurance. 65% have that, like it affects their financial well-being or personal health. As you know, these kids are not small. Rett syndrome patients in their 30s, 40s, they only weigh 70, 80 pounds, not more than 100 pounds. But I have several MECP2 duplication kids, they weigh over 200 pounds. And they are unambulatory, they cannot walk. Think that the parents need to carry when they need to change the diaper or for relocate them. So it's huge, cause huge health problems on the parents as well. So one, as I said, it causes huge anxiety, right? And the other problem, if we do a survey like this, it's how the parents are feeling, right? So I talked to Dr. Peters about it. I think she's thinking maybe it's a good idea, but this is the weakness. For example, you feel anxious, as I told you, but you may not have an anxiety disorder, right? And the other thing is, for example, anxiety is very common. 20%, I just checked it like when I was preparing for a slide. 20% of US adult individuals feels anxious in the last 2 weeks. So it's a very common condition. So my question is, or like in my mind, like to you, will this survey cause problems by putting carrier females on spot? What do you think? Should we do? The other thing is, or from alternative approach, uncovering the problems, potentially find solution for those problems, like similar to Fragile X. If we identify, oh, they are prone to, let's say, premature ovarian failure, right? Then maybe if they plan to have child, they can do like ICSI or other IVF in early life so that they will have a healthy child. So these are the options. So I'm putting it here. You can raise your hands or we can talk afterwards. Let me, Katie has a comment on that. This one?
Yes. That first question. I still do think you have a major epistemological problem.
Uh-huh.
Because the only way
Sorry,
that it's
Katie, one
framed
second.
is
We
how
can all hear.
anxious.
That-
Oh. Hello.
Yep, I can hear.
Okay. So talking about that first question, I still think that you have a big epistemological problem here because the only option is talking about, are you anxious? You don't say something like, are you concerned? Or, right? Like the language that is being used here to frame parents' feelings is really important. So you've already put parents in a situation when they're answering that question to have to say, I'm anxious about it. So
That's not a correctly directed question.
Right.
I got
Okay.
what
So
you
that's what I wonder is like, is there a way that we could be more careful about how we use language around carrier mothers? I think that's very important for us. If you're going to do any of that research, that's
One wonderful input. Well, first of all, like we are lucky. Katie's experience is survey development as well, so that brings advantage. Yeah, the question needs to be asked very well, right? Like if you say, "Are you anxious about your child's future?" Any MECP2 duplication, every human being will say yes to that, right? So you're right about it. We need to ask the questions very carefully. Let me say that I am not a kind of survey expert. That's why we need expertise on that, gather maybe professional help, ask these questions in a way that we should frame it in a way that we will get the most accurate answers. As you said, this wasn't probably a good way of asking. Yeah, perfect, yeah. No, we'll get, like when I have developed something, I mostly run with the parents, and I always thankful for Katie to get her critical input. Okay, wonderful. Any other? Let me ask that. You can raise your hands. It's gonna give me a gross ballpark. Raise your hands if you think that a survey needs to, this kind of things needs to be done. If you don't mind, yeah. All right. So raise your hands like, oh, it should not be done. All right. All right. You can email me. I'm gonna give you my email as well. I grossly had like a gross idea about it, but thank you so much for the input. All right. Okay, so I am almost getting closer to my end of my presentation. There are two things I wanted to mention again. This is like MECP2 duplication is like relatively still new. It's like there in the last now 17 years. It's not new anymore, I guess, right? After the first discovery. But we are still learning it. Like I know that there was a French cohort study, they found pulmonary hypertension, the pressure increase in the lung vessels, okay? It is a very severe condition. It caused that very quickly, I know that. So they found in 2 patients, I think, in the French cohort. So we had a patient, it was a 14-year-old MECP2 duplication, came to Texas Children's Hospital, did unexplained fluid accumulation, that's called pericardial, in his lungs and around his lungs and around his heart. That's called pericardial and pleural. Pleural is around the lung, effusion. Normally, you see this in either one infection, 2 tumor. There may be tumor producing some inflammation, attracts fluid. So there was no signs of infection. This kid was really sick in the ICU for 2-3 months. So our smart rheumatologist, because it's the autoimmune condition, checked the markers and the immune markers and everything, decided to treat him with the anakinra, colchicine, and sulfasalazine. Basically, long story short, some immune suppressive medications. And the kid remarkably improved from that hospital stay. Cases comes back to back mostly. A year later or so, someone from UCSF, University of California, San Francisco, reached out to Dr. Zogby. We have this kid in the ICU. He's very sick and he's about to die. And we had to resect his colon because his colon died because of these problems. And he has this unexplained fluid accumulation. So I communicated with the doctors, ICU doctors, and we started with our rheumatologist support, we started them on the same treatment. The kid recovered from that again. Okay. So I said, well, is it coincidental for MECP2 duplication or not? So we had only 17 patients who had immune workup. So I have a student I am mentoring. So she was looking at the immune work. She told me that there's another case. And I told her to write these 2 cases. She said there's another case at Texas Children that I don't remember, and he's not my patient, 12 years old, who had, again, the similar accumulation, but they put him on this colchicine treatment, anti-inflammatory treatment, and patient is stable on it for 5-6 years now. So I don't know if there is any other case in UK, or if you heard anyone who has this like unexplained. I think this needs to be published, so that's going to increase awareness, because the problem is they keep drawing the kind of collecting those fluid, but it keeps accumulating there again. So the treatment, if you don't do it, immune suppressive treatment, they don't recover. And they are very sick. As I said, they are about to die. So they become that sick. So I think it needs to be published to guide people, and we are going to work on it. I just wanted to let you know on that. And if you hear any case like that who has fluid accumulation, just let us know. As I said, we are learning this disease. There is a question in the back. Neslihan, carry the mic. Helen, give it to the girls. They should do some work. Go faster, go faster.
Hi.
Hi.
Yes, my son had pericardial effusion.
Okay.
And he had the fluid drained. And after that, they just tried loads of different antibiotics, steroids.
Yeah.
He did recover, but it took a very long time.
Got it, okay.
Yeah.
How sick he was? Like, was he sick, too sick, or he was mild?
Really, yeah.
Okay.
In ICU, yeah.
Okay,
Yeah.
got it.
But
Yeah.
the trouble is, because of everything MECP2 has going on
Yeah.
in it, the only reason they found it is because I insisted on a scan.
Uh-huh.
And that's how they found that you had the fluid
Wow,
there.
yeah.
Yeah.
Well,
So-
thank you for the input. Like,
Yeah.
well, this shows that I don't know if your child get any of these immune suppressive treatments. There's a chance that like his immune system fought for it, and maybe it helped with that. So you don't have to maybe have in everyone, but all I know is our cases, they were about to die. At least these
Yes, he
first
was
two.
he was seriously
Yeah.
ill.
Yeah. So thank you so much. At least we have one more, and like I'll share my email, and maybe we should have your doctor to participate with that, so that it's going to increase awareness.
Thank you.
Well, actually, thank you so much for the input. This comes to my last slide. Expert opinion paper on clinical management, okay? As I publish and I communicate with the families, right? I get a lot of calls from the US, also from all around the world. And I can say that there are 6 kids that I know now are very sick in ICU in all around the world, not only US, I am saying, okay? So, and I tried to do a call on my way to here. It didn't work out. I did 2, whatever. So I do this kind of talking to the local doctors. To be honest, I am a neurologist. But let me say this part. Overall, what is my impression about this condition, okay? I know that the doctors mostly don't listen to the parents, okay? This is my outcome. As she pointed out, she insisted to screen the kids' lungs or whatever. Eventually, they figured it out. This is what I know, okay? So after doing all those calls, or like participating in their meetings, definitely there is a gut feeling of the parents. They know that something is wrong with their child, but doctors say, no, his vitals are okay. Why are we screening his blood? Well, just do it. It's not going to cost you money too much, whatever, right? So they don't listen, I know. Will an expert paper opinion written by, let's say, neurology, gastropulmonology will help or not? The question is, there is nothing specific to MECP2 duplication in general. Maybe that pleural effusion, whatever. But in general, we are going to just say that, oh, treatment is similar, whatever. So it's not going to change too much. So this is just an idea. Do you think that's going to help? Maybe if you go to doctors. But the key points for that paper will be, 1, I know several things. 1, for example, to put on the either IVIG, this is after they turn 10, they are getting frequent lung infections, or prophylactic antibiotic, or something this like pericardial effusion. Be careful about it. So do you think a paper will be helpful? Anyone who says yes? All right. Okay, I got my answer. All right. All right. Any questions, always reach out to me. I am happy to respond. Don't feel shy, definitely, about, taking my time. My main time is for families, okay? Families first, then definitely the other things come second. There's one question there. Yes, yeah. Or Amelia, yeah. Go, there's one. What?
Hi, my son Arthur is 9 years old and he's got a PEG J. His surgeon is actually querying whether he has Hirschsprung's disease and they want to do a biopsy. However, all the literature says that constipation is part of the clinical picture.
Yeah.
And so I'm a bit reluctant to let him have a general anaesthetic to test for Hirschsprung's. Have you ever seen this in children with MECP2?
Very common. Yeah, I saw it. So I don't think that your child has Hirschsprung. Hirschsprung is this. Okay, this is, let's say, colon. And around the colon, the colon is just a kind of a tube, right? That tube has a nervous system. And when that nervous system is not developed, that's called Hirschsprung's disease. That's why it doesn't move forward. Motility is not working. It is not the case in MECP2 duplication. The problem is, again, MECP2 duplication is causing to be lazy. That nervous system works well. I don't know if you know. I know, there are that's called ileus. Okay, ileus means your bowels. No, it's the volvulus. The ileus means normally your bowels are making this peristaltism, this move. That's why the food or the poop in it goes forward. So they don't make it. They are lazy. They are just paralyzed, sits there. So the treatment it's the biggest thing. That's why I put the GI in there. Yeah, and I know several kids who had to undergo colonoscopy took the poop out, right? So this is one thing, like a key point. But I know that with a very strong medication regimen, there is no mechanical treatment. Oh, the surgeon will go or cut it. So it doesn't work. But it goes to the level that, as I said, the UCSF case, it can be that, but that ileus is causing, they have to cut some parts of the bowels or the colon most, yeah.
Okay, thank you.
And you can ask me in the coffee breaks and everything these questions as well. So I took too much time, I guess. Amelia, I am a dad, right? So I have to push her.
You had said that that sleep apnea was super common when you guys looked at it. Did you guys look at central versus obstructive for that at all? We went through that with our son and kind of didn't realize he was obstructing at night. And ended up taking his tonsils out, but that's a huge difference for families, the way that it needs to be managed,
exactly.
Whether or not they're obstructing because their tone's super low or their tonsils are really big, versus there are other genetic syndromes where they actually just stop breathing, and that's more central. It's just their brain's not sending the signal. That's really common, like Down syndrome, and I think that makes a huge difference in management. So did you guys look at that?
Yeah, we looked at it. I think that we mentioned it in the paper. So there are two types of sleep apnea. One is obstructive, as Amelia said. Your airway is, because of the low tone, is kind of collapsed. It's not open enough. That's why it's called obstructive sleep apnea in the airway. The second one is central sleep apnea. Your brain is not giving enough command to your lungs to breathe in and out. So that's called central. So in MECP2 duplication, all of our cases had mild obstructive sleep apnea. When they get older, it can be moderate, but still obstructive. We have only a few MECP2 duplication syndrome who has central sleep apnea, but their triplication and triplication cases had it, I think. Also, maybe translocation case. In general, I would say almost all of them are mild obstructive sleep apnea. As Amelia said, the treatment is if you're living in an allergic area, I think UK is a very high allergy area because of the trees and everything. So they put allergy medications. And if it doesn't work, they take the tonsils out, and that fixes the problem. This is the majority of the cases in MECP2 duplication.
And I think the other thing that was going for us at the time, which is interesting when you talk about the effusions, is that we were having PFAPA type symptoms with him. And so PFAP is when your immune system is essentially, your tonsillar tissue is kind of overactive and you have these periodic fevers. And so that's what we were getting worked up for. And it's interesting to think maybe there is this component of their immune system that's maybe a little overreactive, and that changed our lives to get tonsils out big time.
Yeah,
Like,
so frequent infections may go down significantly in MECP2 duplication syndrome. So I split MECP2 duplication infections into two different areas. One, in the first 10 years, you can say. This is more common, like for example, our kids go to daycare, right? They get a lot of bugs in there, and they get frequent infections from that. That is more common, like upper airway infection, whatever. When they get older, seizures kicks in, very sick, then they start having more severe aspiration pneumonia and everything. I don't know, at least in US, I don't see too much aspiration pneumonia. Well, it happens, but more upper airway related, and then maybe it goes to the lungs. As you said, when you take the tonsils out, mostly it decreases the frequency of infection significantly, definitely.
So I think that goes to those clinical guidelines. You know, when we got ear tubes in, when he was 18 months, I said, hey, there's this study that shows some huge percentage of these kids get their tonsils out. Can you do it when we do the surgery? And the ENT said, nah, let's just wait. And then 4 years later, we get them out. And it would be nice to have a clinical guideline just to say, you know, if you're considering putting this kid under for adenoidectomy, go ahead and take their tonsils, because it's like a 70, you know, it just would be nice.
Yeah.
In an ideal world, we'd have statistics on this and guidelines.
Well, it's very nice to point it. Like, so I think what the families don't, or the doctors don't get, what they don't get. For example, that's true, like ear tube, right? Like, oh, my kid has had like 3 ear infections in the last 1 to 2 years. Can we put a tube? They consider that child as a normal normal developing kid, normal immune system. That's why they say, no, let's wait. So then it's caused more and more hospitalization. They just have a lower threshold and more support. And I think that's going to take care of MECP2 duplication symptoms a lot. Just to let you know, we did, and also Ionis natural history study, we are doing the immune workup significantly. We didn't find a clear immunodeficiency too much. But there is some still we couldn't figure out. I just want to let you know that, yeah. KD?
Yeah, I think it would also
Dr.
be helpful. We just had our clinical guide rewritten, and a couple of your buddies, one at Texas Children's, does feel that there are certain things that you need to look out for. Like, even if it looks like a typical kid thing, they're actually, like you were just saying, like, there are things that you would need to do specifically for MECP2 care. So, yeah, I'd love to see, like,
I know, yeah,
all
you
come
have
together.
that part, yeah.
Can we bring that, like, where we get a lot of the expertise together?
If it is, for example, if it is published by the, like, as you said, family organization can have that, but as a expert team member together, that's a great idea. The only problem is, as I said, like, we are not saying, oh, normally you treat with this in MECP2 duplication. So it's not. But as you said, these points are important for them. And maybe in each section, we need to bold them, saying that, okay, be aware that these kids are prone to sleep apnea. So these are the mostly what we see, and maybe be careful with this, something like that. There was one comment in the back. Nisyan. Take it.
Just a comment.
Dr. Groppel from Austria, I think you all know.
Sorry, Dr. Groppel, Austria. There's very good literature about sleep apnea and tonsillectomy in well-developed children, that they are losing the skills, the cognitive skills, and that they cannot perform in school as good as anymore. So here we are talking about children who already have problems in the development. Yeah. So we have to be very, very careful to take away all negative factors who influence the development also. So in this case, I recommend to go earlier for tonsillectomy, because we're talking about a very sensitive patient population. This is just
Thank you, Dr. Groppel. I think we should have Dr. Van Asch and you in that paper as well to bring the diversity to European overall. Yeah. Thank you so much for your time.
Can I have
sure.
one last question?
Of course.
You said something about the urinary tract, about kidney stones, and there are some cases we read about urinary retention.
Urinary retention is later in the life after seizures again.
Yes.
Yeah, this is common. Urinary retention and UTIs are more common later in the life.
What's the most efficient way of dealing with that?
Well, I am not a urologist, but I can say for some of my kids, I can say it definitely depends on the child. I have a urologist, I like her a lot. So she definitely tailors. For some kids, she does every 4-hour catheterization. For some, she merges with them, like there's an oxybutynin to prophylactic. So there's different approaches. I think urology be in there. Yeah, I didn't think about it, but a urologist, I think, is a great idea for that as well.
Yes, I think it should be
especially older age
inside the
kids.
panel of expertise. You need also a urologist, since we read that's for 36%, and as you said later,
Exactly, yeah.
it's
It's
gonna
not
be
an
needed.
early age problem.
Because the common urologist, even child urologist, have an issue on dealing with this.
So yeah, that's the thing. Like I realized that like this disease has its own nature. I think, Paul, in this retrospective data, we need to look like we can show it. I try to publish something natural history of the disease. For example, I know that UTI happens later in over the urinary retention, but I tried to gather from my 100 patients. I couldn't get that. I couldn't show the data to publish it. Okay, but yeah, thank you so much for the input there as well. Thank you all.
Thank you very much, Dr. Pehlivan.